And DVT visits to emergency room about 236,000 a year, and the same number is for primary care physicians. Ultrasound used for all venous diseases about increased from 7% in 2001 to 22% in 2006, because there are more and more doctors that are just getting venous duplex scanners in the office just to diagnose mostly DVT, not life-threatening condition. And ultrasound diagnosis of DVT is 3 times more likely than non-DVT, which is for me really surprising, because the non-DVT is usually comprises majority of the reasons for patient symptoms of venous problems. And non-DVT venous disease is much more likely to be seen by a surgeon with odds ratio of almost 5 than a PCP. That is explanation of symptoms, because patients who vascular surgeons or vascular specialists that are seeing patients with venous symptoms, they found more non-DVT reasons for their symptoms. And office visits for non-DVT by surgeons increase. Again, the same thing, we're just gonna go to the duplex scan that became a new gold standard for diagnosis of insufficiency, DVT, and non-venous disease. Why is that? Because there are tremendous advantages to duplex scanning. It's non-invasive, it's safe, no contrast, it's cheap, it's portable, reproducible, it gives anatomic and real-time hemodynamic information. It can be done in various positions, supine, prone, upright, reversed, and Bellenberg, and we can flip a patient, stand him up, laying down, during the same exam multiple times without any problems. Limitations: it's operative dependent, can take time. Not every venous duplex that is done in the United States is done by a person who knows what they're doing. It gives a limited field of view. It requires patient cooperation. Sometimes it can be lengthy. Technical limitations such wound, gas interposition, depth, pain, and etc. Diagnosis: we know that the larger the vein, the more chance of it having reflux. That will explain patient symptoms. Again, the criteria varies. We use in our lab mostly 500 for all veins. We really don't differentiate between the saphenous and femoral popliteal reflux. 30% of the tests done in ICAVL accredited vascular laboratories are venous duplex. That is to diagnose various thrombosis and non-thrombosis, which I'm going to talk about, and just to highlight what else can we find except for thrombosis. And just to give you a little bit of highlight, why do we have these problems in the United States and dilemma. The majority of venous duplex scans that are done in the emergency room in non-vascular surgeon offices are the ones that are done by the labs that have the American College of Radiology protocol accreditation. All you have to do is compress common femoral junction, femoral and popliteal vein, and obtain femoral in the common femoral or external iliac vein and popliteal vein. So all you have to do is rule out acute, life-threatening femoral popliteal DVT. And majority of laboratories that performed the study limited the protocol for inpatients as well as outpatients for these outlines. In misses infrapopliteal DVT, chronic, superficial thrombophlebitis, venous reflux, and non-venous and non-thrombotic symptomatic pathology. So it's not like in Brazil where you have very qualified angiologists and doctors who know what they're doing. They do extensive venous ultrasound evaluation of the patient and found exactly what is the problem, what can be done, what should be done, and relay this information to vascular surgeon, to any other specialist that will address the patient's problems. So the primary care physician understands the patient who comes and says, "Doc, I have swollen leg, my leg hurts, my legs hurt." You probably have venous problem. They send it to one of the ACR accredited lab. It comes the report, no acute femoral popliteal DVT, meaning negative study. So the patient's unhappy, referring physician is unhappy. So on the contrary, whenever you have the ICAVL accredited laboratory, then we have other information. So we just took the 1,200 consecutive patients in our lab, the outpatient, over a little bit a year and a half, picked up our complete outpatient duplex exam and decided to compare diagnostic yield of non-thrombotic versus non-venous pathology, acute versus chronic thrombosis, femoral popliteal versus infrapopliteal, DVT versus superficial thrombophlebitis, and found that positive tests were in 70% of the patients, meaning 70% of the patients who came to vascular surgeon who had ICAVL accredited laboratory, probably similar to vascular surgeons in Brazil or angiologists in Brazil, found an answer why they had problems with the legs and with the veins. 15% were thrombotic. And acute fem-pop DVT was only in less than 2% of the patients. Acute infrapopliteal was in 3%. Additionally, chronic DVT was another 3%, superficial thrombophlebitis in 7%. And non-thrombotic findings was in 55% of the patient. 30% had deep venous reflux, Additional 17.5% has superficial vein reflux. Masses comprised 5%. This is solid mass, cystic mass. This is just dilated popliteal vein with erythrocyte clouding. There's no DVT, but somewhere else it could have been interpreted as a DVT. And this is the large great saphenous vein aneurysm at the origin. Do not miss the dilatation of the vein at the valve area with the large aneurysm that is filled with a clot. And we found that fem popliteal duplex scan to rule out acute DVT would have only give less than 2% positive yield, and ICV accreditation give additional 3% infrapopliteal acute DVT for outpatients and 10% more chronic DVT and superficial thrombophlebitis. And we also found up to 55% of non-thrombotic causes of patient symptoms in the outpatient lab. And again, so what we do, we place patient in either standing if they could tolerate, reverse Trendelenburg, various indications, as I mentioned before, manual calf compression, and assess all deep and superficial veins on the thigh and the calf. And the goal is to recommend treatment because patients come with a problem and they asking the doctor, what can you help us? Mostly we try to help patients with venous closure of the great saphenous, small saphenous, or radio frequency ablation of the perforatus, and also iliac veins angioplasty stenting. So we assess the saphenous vein, reflux, could be normal, mild, severe, perforated vein, like for example, this one has the flow directly pointing towards the skin. Not only it's a large perforator, but it also has the flow that is just going directly to the surface. For the inpatient, we limit the assessment to actually follow up and rule out acute DVT and preoperative great saphenous vein on only 10% of the cases. Why? Because the hospitals don't want to have diagnosis of DVT as they're marked on the studies, because for them acute or chronic, the hospital is going to be punished, and now it's going to be financial in the United States for having an inpatient diagnosis of DVT, because there's no differentiation between acute or chronic. Also, they do not like to diagnose infrapopliteal DVT clearly, because first of all, the last chest journal recommendations, and which is already on every single board for surgery, vascular surgery, internal medicine, said that infrapopliteal DVT treatment is serial imaging. Whenever you found acute infrapopliteal DVT, you do not anticoagulate the patient, you just have to bring it for serial imaging to look for extension of the clot. So the radiologist only looking to fem-pop, vascular labs looking in below the knee, but we do not report it. So again, we looked at our experience, found 4,000 lower extremity duplexes in 3,000 hospital patients, equally distributed between male and female. We found also, decided to find out the incidence of pulmonary embolism. So the studies such as VQ scan were requested based on suspicion or this positive CT angio. And we found that over 4,000 duplex scans, the positive for DVT was 17.8%, and PE of those was in 12%. We compared the rate of PE between the isolated fem-pop DVT and different infrapopliteal DVT and different types of infrapopliteal DVT versus posterior tibial peroneal or calf muscular. What we found is the mixed calf muscular and tibial peroneal DVT was basically as common as the femoral popliteal DVT. There was no statistically significant difference, but the incidence was quite significant, almost 16%. We found the rate of PE, it was statistically more significantly evident in the fem-pop DVT, but it was still present in almost 6% of patients with isolated calf muscular vein DVT. Isolated tibia peroneal was as common as isolated femoral popliteal, no statistically significant difference. And this is just the same distribution. So we found a significant number of patients with isolated calf muscular DVTs developed PE, and even higher PE rate noted mixed calf muscular and tibia peroneal DVT. So it's not as benign as it is evident in some institutions or maybe across the board, and both should be treated with the same aggressiveness. Again, also there's some labs that do not look above the groin, and we just wanted to see if we should look above the groin. So iliac caval duplex has some limitations because it's hard to compress abdominal veins, there's gas, there's low flow and depth, but it's important to find DVT, obliteration, congenital abnormalities, compression by cyst mass, May-Thornton syndrome, uterus, bladder, etc. Just want to show a couple of examples. we found just retrospective review, 75 patients with lower extremity edema, but negative venous duplex. Most of these patients were males, age range from 6 to 82. What we found is sometimes the waveform analysis between the one and the other common femoral vein clearly shows difference, and this was abnormal. There was no augmentation with compression, it was monotonous flow. And we found that positive iliocaval findings was in 7 patients. 6 were extrinsic compression of IVC and external iliac vein, and 1 patient had IVC and common iliac vein obliteration. But abnormal common femoral waveform was only in 3% of the patients. So even if you have abnormal common femoral vein waveform, you may miss the suprainguinal abnormality. For example, this is the anterior IVC compression by the mass, where you have the distal IVC flow of 35, and at the level of compression was 170. This is the posterior compression by the enlarged node that was found on the duplex scan. This is the external iliac artery, external iliac vein mass, actually, that showed abnormal waveform. This patient had uterine mass and ovarian mass that she had no idea about, and upon referring her to come to CAT scan, we found that the patient actually had cancer. And this is the IVC obliteration in sagittal and transverse. So when you see it, you can see it. So the conclusion is normal common femoral waveform does not exclude suprainguinal venous compression. Duplex scan is a valuable tool in identifying iliocaval abnormalities in presence of lower extremity edema and negative infrainguinal examination. And when adequate duplex visualization of iliocaval segment is impossible, which is up to 20%, even in qualified hands, other diagnostic modalities, such as I mentioned before, MRV, CTV, or venogram, should be considered to exclude suprainguinal venous pathology. Thank you.
Muito obrigado, Natalie. Na sequência, o programa, então.